So hello everyone and welcome to this advanced coding webinar. And welcome back if you have attended the MedDRA Coding Basics webinar in the last week. Nice to meet you all to go through some additional, more advanced aspects, some examples and exercises on how to perform MedDRA coding. I'm Caroline Wilson and work as a medical officer at the MSSO and will be your instructor today. And I'm supported by my colleague Leander Mold, who was speaking to you before. Together, we will take you through this webinar, which will last for about 2 hours. We would like to make this webinar interactive. Leander mentioned this already, so please submit your questions or send us your comments through the question panel. And I will allow as much time as possible for questions, both during the course and also at the end of the presentation. But please do not raise specific coding questions, as we can't help you with individual verbatim terms, but we can guide you in terms of coding principles. Now let's start. Most of you will know that ICH adopted the development of MedDRA in the mid of the 1990s and became the owner of the terminology. ICH then, on contract, appointed the MSSO to take care of the maintenance and further development of the terminology based on user feedback, to provide and organize corresponding training as the one that we have today, and to administer the MedDRA licenses. And all these MSSO activities are overseen by the ICH MedDRA Management Committee. ICH not only is the owner of MedDRA, but also owns today's training material. It is protected worldwide. You may use the slides with the exception of the MedDRA and ICH logos, but will have to clearly indicate that ICH owns the copyright. Also, any adaptations of the slides have to be clearly labeled. The second bullet point refers to warranty and liability issues you should be aware of. And the third bullet point is not relevant for today because we will not be using any third-party slides. These are the topics that we will cover today. We will first discuss some more advanced principles that are outlined in the Points to Consider document for MedDRA term selection, which is a coding guidance document provided by the ICH. We will then look into the MedDRA concept descriptions and at several advanced coding scenarios. And we will use the PAL Everywhere application and the MedDRA browser to apply some of these advanced concepts from the MedDRA term selection Points to Consider document. Finally, we will go through some tips for coding, what we call the coding pearls, to help you with your coding tasks. And we will conclude with a question and answer session, but as mentioned earlier, you will be able to raise questions throughout the session as well. But again, please understand that it is not in the scope of this training to help you with very specific verbatims that you came across, but rather address the advanced coding principles and related coding scenarios on a more general level. Now let's start. The next two slides explain about the polling. If you would like to join the quizzes and participate in the examples today, there are two ways to do so. The easiest way is to scan this QR code with your smartphone or tablet. Or you may enter the indicated web address, paulf.com, into the URL bar at the top of your internet browser in your computer, tablet, or cell phone. It will then take you to a log on screen and you'll be asked for a username. The poll is completely anonymous, so you don't need to enter your name, but please enter my credentials. That is Carol N. Wills 584 with no spaces. Nothing more to be entered, just click join. And Leander has put these credentials in the chat as well. But you don't have to get under time pressure because you will be able to see these credentials on each slide that relates to the quizzes. Now let's see whether the technology works. Yes, I see Italy, buongiorno. As I see the US, Spain, I think, buenos dias. India is joining, lots of people in Europe, of course. I think it's Taiwan, Russia, Turkey, Merhaba. I'm sitting in Berlin in Germany, and I'm really happy to welcome you all. So we are spread around the world. Africa, we are missing Africa and Australia, but otherwise America is there, Europe, Asia. So welcome. It seems to work. Thank you for joining. And now please let me know whether you have already attended the Coding Basics webinar. I see that many of you did so already, or you are more experienced MedDRA coders. But for all those who did not attend the MedDRA Coding Basics training so far, it is really useful to attend this webinar as well, because it will provide you with really important basic information about the MedDRA structure and some basic principles that should be applied in operational coding from the ICH coding guidance document. Our webinar today builds on it, and I will not be able to go into the details of what is covered in the Coding Basics webinar. So if you have the possibility or the option to join this webinar, please do so. Let us now start with our topic today and first look at the MedDRA term selection points to consider document that provides guidance for operational coding. This is a screenshot of the cover page of the current ICH PTC document for MedDRA term selection for version 28.0. It provides guidance and many examples on how to perform accurate and consistent term selection using MedDRA. This guidance should be the basis for your own coding conventions, your own coding decisions, and intends, of course, to promote overall coding consistency and facilitate common understanding when sharing clinical data. MedDRA allows us to speak with one language when sharing medicinal product safety information between different biopharmaceutical companies, between pharma and CROs, or when talking to regulators. The document was developed and is maintained by an international expert working group appointed by the ICH Management Committee, with members from regulators and industry of the ICH regions, the MSSO, and the Japanese Maintenance Organization, or JMO, and the WHO as an observer. There is one original and comprehensive version that is available in English, Japanese, Chinese, Korean, Spanish, and Russian. It is updated with each major MedDRA version release, that means beginning of March each year. In addition, there are condensed versions of this original full document in other MedDRA languages, except those that I have just mentioned, of course. And you see these languages listed on the slide: Arabic, Brazilian, Portuguese, Czech, Dutch, French, German, Hungarian, Italian, and Portuguese. These condensed versions focus on the general coding principles without going into further details for selected topics. They are not updated with each MedDRA release, but on an as-needed basis, because these basic principles do not change much over time. They are stable. The Coding Basics webinar I've mentioned before focuses on the basic principles for term selection that are outlined in the first part of the PTC document. Today we will focus on specific coding topics, more advanced ones, that are addressed in the second part of the PTC document. And you see the list of these topics here, like diagnosis and provisional diagnosis with or without signs and symptoms, combination terms, age versus event specificity, so what to prioritize in such instances, or body site versus event specificity, modification of pre-existing conditions, medical surgical procedures, etc., etc. And we will cover quite a few of these advanced concepts today, those that are highlighted in yellow, either in separate slides or via practical coding exercises. And the list continues on this slide. You see medication errors, misuse, abuse, addiction, device-related terms, social circumstances, medical social history, off-label use, product quality issues. So a long list of specific topics that are addressed in this ICH guidance document for operational coding. Let's first start with some important general principles which are addressed in the points to consider guidance. We have already discussed them in more detail in the Coding Basics course last week. Coding is done on LLT level, the data entry level, and only current LLTs must be used in ongoing coding. The LLT selected should capture as much information provided by the original verbatim as possible. So this is the basic principle for MedDRA coding, code as reported. So when coding, we should not add or not subtract relevant medical information. As can be seen in this example here, reported is an abscess on the face. This verbatim should not be coded to just abscess because it is medically relevant to also capture the manifestation site that was reported. That is why we would select LLT facial abscess to capture as much information from the report as we can, because an abscess could, of course, affect other parts of the body as well, cerebral abscess, pulmonary abscess, etc. And always remember to select current LLTs only. The non-current LLTs are still in the terminology for historical purposes to support interpretation of legacy data and also legacy data conversion, but they should not be used for ongoing coding. In some instances, you may consider to select more than one MedDRA term to capture the full information of the verbatim. Let's look at the example on this slide. If you are to code the verbatim metastatic gingival cancer, you may decide to select either LLT gingival cancer or LLT metastatic carcinoma to not duplicate the event. But selection of only one term will lead to loss of information, and you would need rules for the prioritization of the information received to ensure coding consistency. But you may also decide to capture the full information and split code by assigning both LLT gingival cancer and LLT metastatic carcinoma. When taking this approach, you would duplicate the event that is the malignant neoplasm information. In the end, you are free to choose either option, what we call lumping or splitting, but make sure to document your rules and to use them consistently. Now let us look at another example for this principle. How would you code left foot and ankle swelling? Would you split this reported event and code to swelling of feet and ankle swelling, or would you lump the information under one of the other LLTs that are shown on the slides? How would you approach this verbatim? Peripheral swelling would be an option for lumping, unilateral leg swelling, or local swelling. I see you voting. Let's see where you're going for. Most of you would split code, would code to swelling of feet and ankle swelling, but others would also select peripheral swelling because it's a peripheral swelling, unilateral leg swelling, or local swelling. So let's see. Let me close this and let's see what the correct approach would be. So splitting would be the correct approach here, namely we would select swelling of feet and ankle swelling because LLT ankle swelling is grouped under joint swelling, whereas LLT swelling of feet is grouped under peripheral swelling. As you can see here, swelling of feet grouped under peripheral swelling, ankle swelling under joint swelling. meaning that we have two different medical concepts in our verbatim, and these have to be coded separately. And the example also nicely shows why checking of the hierarchy when coding is always very useful. Next one, another example for this principle, splitting or lumping. How would you code pain in hand, severe pain in leg, and toe? Would you split this reported event and code pain in hand and pain in leg and pain in toe? Or would you lump this information under one of the other LLTs? How would you approach this verbatim? Pain, musculoskeletal pain, pain in extremity, pain in hand, and pain in leg would be the other option because toe is part of the leg. What would you do? Let's again see. Most of you would split code again. Others would code to pain in extremity or pain in hand and pain in leg. So let me close again this poll. And here we have a different scenario because all reported events can be coded to LLTs that are grouped under one single PT, that is, pain in extremity. In such situations, you would select the LLT that is identical to the PT name. And again, you can see that checking the hierarchy is important. Pain in toe, pain in leg, pain in hand. These three LLTs are grouped under PT, pain in extremity. As indicated before when showing the splitting examples, checking the hierarchy is an important general principle for term selection. Before making a coding decision in more complex cases, it is really advisable to check the MedDRA hierarchy to reassure yourself that you are on the right track. That the selected LLT is medically correct, correctly represented in the MedDRA hierarchy. As an example, a non-infectious condition should not be represented in SOC infections, or a condition that was reported which was acquired later in life should not be coded to a term in SOC congenital. This slide provides an example. If you are to code the verbatim feeling completely drained, you won't find an exact match in MedDRA. You may then consider to assign LLT worn out, but may be unsure whether this is appropriate. But when checking the corresponding PT fatigue and the LLT siblings underneath, like for instance LLT exhaustion or LLT tiredness, you will feel much more comfortable with your coding decision. And when not checking the hierarchy, you may even end up with a completely incorrect code assignment. If a patient suffers a ventricle rupture due to a pre-existing hydrocephalus, the selected MedDRA term should, of course, reside under SOC nervous system disorders. The correct term would be LLT cerebral ventricular rupture. Same PT, and it is grouped under SOC nervous system disorders. When searching for ventricle rupture and not checking the hierarchy, one may assign LLT ventricle rupture. It seems to be a perfect match. But this LLT and PT is grouped under HLT myocardial disorders not elsewhere classified and resides in SOC cardiac. So this is a real-life example that I came across when doing spot checks of code assignments when working in pharma. So it's always good to check the hierarchy to make sure that you are on the right track with the code assignment. Another topic that I would like to highlight today are the concept descriptions. These are descriptions on how a medical concept is interpreted, used, and classified within MedDRA. They do not represent medical definitions, but they may be helpful for you when searching for suitable LLTs. The purpose of the concept description is to support accurate and consistent use of MedDRA in coding and in data retrieval. They intend to help to overcome differences in the use of medical terms worldwide. You will find the concept descriptions in Appendix B of the MedDRA Introductory Guide, but you can also access them in the MSO MedDRA browsers. If you click on the corresponding icon of the MedDRA browser, this window will open. You can then select the appropriate section to view as the concept descriptions are sorted in alphabetical order. So let me show you how to find them. Let me use our legacy web-based browser by clicking on this shortcut here on the MedDRA website. I can log in. And here we are. And you see the MedDRA concept descriptions on the top here. If you click on this icon, increase the size. Here we are in alphabetical order, starting with the A. And you see abuse, acute, angina, arthritis, cancer, carcinoma are considered synonyms in MedDRA. And let me show you the definition of dose, for instance, a quantity to be administered at one time, such as a specified amount of medication, whereas dosage refers to the determination and regulation of the size, frequency, and number of doses, so duration of treatment. So this is a combination term, a broader term than just dose. Overdose. Let's look for overdose. Overdose, for the purposes of term selection and analysis of MedDRA-coded data, overdose is more than the maximum recommended dose in quantity and/or concentration. In other words, an excessive dose. And we have also preparation, so some product quality terms, medication error terms like prescribing error, then product quality terms, product coding incomplete, color issue. Then again, MedDRA terms representing medication errors, product dosage form confusion, label confusion, name confusion, etc. So especially for the product quality terms and for medication errors and other product use issues, it's worthwhile to look into these concept descriptions because the terms that you will find in MedDRA are sometimes very specific. So do we have questions so far, Leander?
No questions so far, thanks, Caroline.
Okay. So then let's continue. And I will now address some of the specific advanced principles addressed in the PTC term selection guidance document. The first advanced principle in the document is the coding of a confirmed or provisional diagnosis with or without signs and symptoms. Well, if we have a single diagnosis without signs and symptoms, which is confirmed, we will only code this diagnosis because this is the only information that we have. If a provisional diagnosis is reported without signs and symptoms, we would take this suspect diagnosis as if it was confirmed and code it accordingly. In parallel, of course, we would ask the reporter for more information whether it was meanwhile confirmed. And the same approach would be taken if you have multiple confirmed or provisional diagnoses without reported signs and symptoms. Next, we have a different coding scenario where either a confirmed or a provisional diagnosis is reported with clinical signs and symptoms. For such coding scenarios, the PTC document provides a preferred and an alternative solution. For a definite diagnosis with signs and symptoms, the preferred option is to only extract and code the diagnosis. And here we have an example. Anaphylactic reaction with rash, dyspnea, hypotension, and laryngospasm. Then we would select anaphylactic reaction only, because these signs and symptoms are characteristic for the given diagnosis. And in the case of signs and symptoms that are reported with one provisional suspect diagnosis, all signs and symptoms and the provisional diagnosis are to be coded. In case signs and symptoms are reported with several suspect diagnoses, all signs and symptoms and all provisional diagnoses are to be coded. Alternatively, signs and symptoms can be coded in addition to the diagnosis when having a definite diagnosis. Or only the signs and symptoms may be coded without the single suspect diagnosis, because the provisional diagnosis may of course change. Again, the same rules apply for multiple confirmed or suspect diagnoses. Both options, the preferred one and the alternative option, can be selected, but the approach chosen by the MedDRA user has to be applied consistently in your organization and needs to be documented in the coding conventions. Be aware that taking the preferred option is always simpler, would lead to a leaner database, to less noise in your database. When taking the alternative approach, you would be on the safe side, not omit important information, but data retrieval and analysis may be more complex. However, one cautionary remark when taking the preferred approach. The PTC document clearly states that signs and symptoms that are not associated with the diagnosis, that are not typical for the diagnosis, will always have to be extracted and coded separately. And this, honestly, even with sound medical background, this is something sometimes really hard to decide. Clinical signs and symptoms are often not pathognomonic, so meaning that they do not point at only one diagnosis, but could relate to many. And you see here an example from the Points to Consider document. Of course, it's quite straightforward. Myocardial infarction, chest pain, dyspnea, diaphoresis, ECG changes, and jaundice. Of course, in such an instance, you would consider chest pain, dyspnea, diaphoresis, and the ECG changes as characteristic for the myocardial infarction, not the jaundice. So you would code the jaundice separately. This is quite obvious, but sometimes this decision is really hard to make. Let's have a look at an example for this topic. Here we have two suspect diagnoses plus related signs and symptoms. Sepsis leading to shock from possible spontaneous bacterial peritonitis or bowel perforation. Which LLT or LLTs would you select based on what you've just heard? Applying the preferred approach. This is the one that we always use in our webinar, the preferred approach. You can select more than one term here, and it's not necessary to search in your browser. Just apply the principles we have just addressed and select the most appropriate LLTs. Sepsis, shock, septic shock, spontaneous bacterial peritonitis, and or bowel perforation would be the options here. Oh, we have a split of opinions. So you would code both suspect diagnosis and you would code the septic shock, but others would split code and code sepsis and shock separately. Let me close the poll and let's check your answers. We have to capture both provisional diagnoses. Perfectly right. And for the provisional diagnosis, the preferred option provided by the PTC document asks us to code the associated symptoms in addition. And here we have split of opinions. Some of you would split into sepsis and shock, but the majority prefers to code to septic shock, and this is fully correct. We can assign a combination term that captures both the reported sepsis and the shock condition. So we have to capture both provisional diagnoses, and for the provisional diagnosis, the preferred option provided by the Points to Consider document asks us to code the associated symptoms in addition. So the correct approach is to code both spontaneous bacterial peritonitis and bowel perforation, so the both suspect diagnosis and the related clinical conditions, the septic shock. Any questions? Jane, sorry, Leander.
That's no problem, Caroline. No, there's no questions. Thank you.
Okay, another frequent problem area is the reporting of conflicting or ambiguous information, and the slide provides two examples from the PTC document. If no clarification can be obtained, you will have to find an adequate coding solution for such coding scenarios. In the first example, the diagnosis hyperkalemia does not match the lab result that rather indicates hypokalemia. The recommended coding approach for such scenarios is to code to the respective abnormal MedDRA LLTs. Coding then covers the fact that the lab result is not normal, but doesn't make any assumptions whether it is below or above the normal range. And important to mention is that coders are frequently confronted with numerical values for lab values that need classification as high, low, increased, decreased. It is advisable to add one or two references like the Oxford or Harrison's textbook of medicine to the coding conventions that are to be used as a standard, as a reference for your coders, so that this is handled consistently in your organization. A different scenario is shown in the second example, where we see an ambiguous abbreviation that could indicate either genitourinary or gastric ulcer pain. If we cannot obtain clarification from the reporter, the best solution is to code to the underlying basic medical concept, that is pain. If confronted with abbreviations, check in some references like dictionaries for medical abbreviations in order to find out whether on an international basis this abbreviation will always mean the same thing, meaning that it is not ambiguous. MedDRA contains abbreviations, but only if they are non-ambiguous. Especially when receiving consumer reports in pharmacovigilance, vague information may be reported and there may be no chance for further clarification. Turn green is a nice example, could relate to the skin or tongue of the patient, but also to a drug like a capsule or cream that has changed color. So we do not even know whether this is something that affects the patient. That is why we would code similar verbatims to LLT unavailable event. If we knew that there is something wrong with the patient, as shown in the second example here, we would choose LLT ill-defined disorder. MedDRA includes several LLTs and PTs in SOC General that can be used for such vague scenarios where we know that the patient is affected, like for instance also PT general symptom or PT local reaction. So more vague terms that can be used to make clear that there is a vaguely reported condition that affects the patient. Now let's stop here again and see if you have any questions that you would like to ask. Do we have questions, Leander? Just to make
No
sure
questions. Thank you, Caroline. No questions at the moment. Thank you.
Okay, thank you. So from what you've just heard, how would you approach this verbatim? Patient had an MI. Would you code it to myocardial infarction, ill-defined disorder, MI, or would you select unavailable event? What would you do with such a verbatim? Had MI. Let's see what you're going to. Oh, split of opinions. Many of you would go for unavailable event, but others to myocardial infarction, ill-defined disorder, MI. So let me close. It says MI in the term, and we could follow the wording in the term. So LLT MI would definitely be closest to our verbatim. But there's something about this term. It is an abbreviation, and we would need to make sure that it is unambiguous. Does it always mean myocardial infarction, or could it mean something else? So we would need to look it up in an abbreviations book or other medical reference book. And we would see that it may relate to myocardial infarction, but also to myocardial ischemia, mitral insufficiency, mental illness, mesenteric ischemia, etc. We can't assume that it means myocardial infarction. Can we select MI in MedDRA? So let's check in the browser. Here it is again. And let me just enter MI and search. Whoops. Yeah, and you see that our search has, of course, returned too many results to display. So here the advanced search option comes into play. That is, we say we want to have an exact match MI. And I would search again. And here is MI. And you immediately see that this LLT is in red lettering and with a red square around it, indicating that this is a non-current LLT. It is, let me right mouse click. Oops, doesn't work. Here we are. Go to browser. It is grouped under myocardial infarction because this is the most frequently used of this abbreviation, but it is an ambiguous abbreviation, and that's why this LLT MI and also post MI is has a non-current status. So just to show you, let me switch back to my presentation. Here we are. So the most appropriate code assignment would be unavailable event for this coding scenario, if no more information can be obtained, because we even don't know that this really affected was a condition in the patient, because MI could also relate to a medical investigation, could stand for medical investigation, so not a condition in the patient. So let's stop again and see if you have any questions. Other questions, Leander, before continuing?
There are no questions, thanks, Caroline.
So hopefully everything
Oh,
is fully
actually,
clear.
there's one just popped in. There's just
Yeah.
popped in. If it is specified as drug has caused a problem health issue, can we not code adverse event as the event occurred post-drug administration?
Yes, of course. If it's clear that something occurred during drug administration, you could say adverse event, yeah. Or if causality is delivered and it says that it was drug related as adverse reaction, but this is what was not the case here. So it really depends on the wording of your verbatim and the information that you get.
Thanks, Caroline. No other questions.
Okay. Next topic. When coding investigational results, please remember the following. MedDRA includes medical conditions in the relevant system organ classes, plus related investigational results like lab results in SOC investigations. And therefore, it is important to make this distinction. It is a fundamental rule in MedDRA that you should not change internally. Remember the basic MedDRA coding rule, code as reported, meaning that if a medical condition is reported, code as such. And when an investigational result, like a lab value, is reported, select a term from SOC investigations. Never interpret a lab test result as a diagnosis. So hypoglycemia should be coded as hypoglycemia. It would then reside in SOC metabolism and nutrition disorders, whereas the decreased glucose resides in SOC investigations. When receiving precise reports on investigational results, like in the first example here, there are no problems. The value is clearly below the reference range and the verbatim can be coded to LLT glucose low. But often, investigational results are reported without units, like in the second example here. We don't know whether this refers to 40 milligrams per deciliter, which would be low, or 40 millimoles per liter, which would be high. Such reports are ambiguous and should be coded to a suitable abnormal LLT if there is no option for further clarification. In order to classify lab values as low or high, not just decreased or increased, you will need standard references to decide whether the reported value is clearly below or above the normal range. As mentioned earlier already when talking about the reported hyperkalemia with the conflicting lab value. So references are always needed, and it would be good if your organization has a standard reference for the coders so that these lab numerical values are handled consistently. Quite frequently, a diagnosis is reported with the corresponding lab values. In such cases, you are not obliged to capture the diagnosis plus the investigational result, as long, of course, as these are consistent with the diagnosis. Because when a hyperkalemia is reported with an investigational result that supports this diagnosis, like in the first example here, splitting would lead to redundant information. So that's not necessary. Not necessary to split in such coding scenarios. But when would splitting of investigational results become necessary? Let's have a look at the second example here, where 4 different abnormal liver function tests results are reported. Increased alkaline phosphatase, increased SGBT, increased SGOT, and elevated LDH. Remember the fundamental principle MedDRA coding rule. Code as reported, so do not omit parts of the reported events. Do not lump these reported findings under one LLT, like for instance, liver function tests abnormal, but split and code each of the specific reported findings separately. Another example for you to try. Testing showed increased serum creatinine and BUN with increased BUN creatinine ratio. How would you code this verbatim? Which LLT or LLTs would you select? Increased serum creatinine, BUN increased, blood urea nitrogen creatinine ratio increased, or would you select renal function tests NOS abnormal? Exactly. Most of you are going in the correct direction here. You would not omit any information. You would code everything that you've got. So the increased serum creatinine, the BUN increase, the blood urea nitrogen creatinine ratio increase, and you would not lump this information into under one LLT that you select, like renal function tests NOS abnormal. Well done. Thank you for joining. So here we are. The first 3 options would be the correct code assignments for this verbatim. Next one. Let's have a look at this one. This patient had features of aldosterone excess. How would you approach this one? Would you select aldosterone increased, aldosteronism, or blood aldosterone abnormal? So this example is tricky. Patient had features of aldosterone excess. Split of opinion. Most of you are going for blood aldosterone abnormal, aldosteronism, or aldosterone increased. So let me close the poll so that you cannot change your mind anymore. So let's look at this verbatim again. Here, no investigational result is reported. We are not told that the aldosterone was measured and resulted to be excessive. But it is reported that the patient had signs and symptoms, features of an aldosterone excess. It is a condition in the patient. And that is why we would select LLT aldosteronism for this verbatim. So it's always important to really look at the verbatim and be fully clear about what is actually reported here. Is it an investigational finding or is it a condition in the patient? And here clearly a condition in the patient is described. Questions, Leander?
No questions. Thanks, Caroline.
Okay. So here comes the next advanced coding principle, combination terms. The first example on the slide refers to such a term, but not to a diagnosis with signs and symptoms as we saw earlier, but to terms that relate to the same overarching medical concept, but where one is more specific than the other. So here we have two examples. Arrhythmia due to atrial fibrillation. Atrial fibrillation is the more specific type of arrhythmia, so we would code this verbatim to atrial fibrillation because atrial fibrillation is an arrhythmia. Hepatic function disorder that is specified as acute hepatitis. Again, we code to the specific type of hepatic function disorder, the acute hepatitis. But sometimes you'll see that MedDRA has combination terms which relate to two separate medical concepts. For instance, combining a defined medical condition with its etiology or other additional attributes. Remember our previous example with the sepsis and the shock where we found a combination term septic shock. And here we have additional examples. Retinopathy due to diabetes can be coded to a perfect combination term, diabetic retinopathy. Rash with itching can be coded to itchy rash. Breast cancer, HER2 positive, can be coded to HER2 positive breast cancer. HER2 stands for human epidermal growth factor receptor 2, and its overexpression promotes the growth of cancer cells, meaning that its presence has a significant impact on treatment decisions and the prognosis of the patients, and it needs to be captured when reported. And again, you'll find a perfect combination term in MedDRA which captures the full information. If you get a verbatim representing combination of relevant clinical information and no corresponding combination term is available in MedDRA, then you should split code. You should select more than one LLT to capture all relevant medical information. In the first example, we would split and code two LLTs, diarrhea and vomiting. We wouldn't lump this information under a more vague LLT like gastrointestinal upset, for instance. In the next example, a wrist fracture due to fall is reported. Again, capture all information. The fall may have been caused by the drug because it made the patient feel dizzy, for instance. So you have to capture all information to be able to search for it in your database, to be able to look for patterns and safety signals. When we have a BRAF positive malignant melanoma, again, split this information to capture both the specific malignancy and the gene mutation because, again, it is relevant for therapy decisions and for the prognosis of the patient. Now it is your turn again. Here we have a retinal disease from HIV with near total blindness right and left. Which LLTs would you select? I give you a minute to vote. More than one term is to be selected in this case, of course. What would you select? Retinal disorders, disorder, HIV disease, blindness, HIV retinopathy, or blindness, both eyes. Most of you are going for HIV retinopathy and blindness, both eyes. So we have, again, a perfect combination term combining the information retinal disease from HIV, that is HIV retinopathy, and this and the blindness, the total blindness, right and left, cannot be considered characteristic signs and symptoms of the HIV retinopathy, but it's really a complication, a sequela of the HIV retinopathy that has to be captured separately. And of course, as specifically as possible, meaning by assigning blindness both eyes, because we know both eyes are affected. So here we are. You would select the last two LLTs, that is HIV retinopathy and blindness both eyes. So are there questions, Leander? Any related questions?
We've had a question from somebody in relation to in clinical trials. We often have the problem that wrist fracture is reported as SAE, and in the narrative it is described that the patient fell down the stairs and broke his wrist. Principally,
Yes.
we asked the investigator to also report the fall so that both events could be coded in the safety clinical database and the safety database. Is this the correct approach?
Yes, it is the correct approach. Definitely. So if the patient fell down the stairs, so it's a fall, and you should capture it. And of course, based on then you would also have to capture the complication of that happened after the fall, that is the wrist fracture. And I would not assume that it's a traumatic fracture, because it could be that it was not a bad fall, so could be a pre-existing disease in the wrist, or it could be osteoporosis whatsoever. So I would never assume that based on a fall that this is a traumatic fracture. That would be an assumption as well. So let's
Thank you,
continue.
Caroline, and
Yeah.
thank you. No other questions at this time, and we've had a response saying thank you for your answer. Thank you.
Yeah. Well, welcome. So the next advanced topic are medication errors. A medication error is any unintentional and preventable event that may result in the improper use of medication or harm to the patient while the medication is under the control of those involved in the medication use process, meaning physicians, pharmacists, nurses, patients, consumers, or their family members. The second aspect that is highlighted in green is important to remember. These errors occur during product use in the medication use process, when the product is under the control of the healthcare provider, patient, or consumer. The term does not refer to errors that occur during manufacturing or are caused by wholesalers, in other words, outside of the control of the healthcare provider, patient, or consumer. If a medication error is reported with clinical consequences, like in the first example, patient was administered wrong drug and experienced hypotension, both the medication error and the consequence of the error needs to be captured. So the closest matches are LLT wrong drug administered and LLT hypotension. In the second example, it is reported that because of similar sounding drug names, the wrong drug was dispensed. As a result, the patient took the wrong drug and experienced a rash. We have four interrelated events here. First, the wrong drug was dispensed. And the report also states the contributing factor, that the two drug names sounded alike. The consequent error is the administration of the wrong drug, leading to a rash in the patient. It is a chain of events, and all reported events have to be captured. And in the third example, it is reported that insulin was given using the wrong syringe. Here we have three interrelated events. The insulin given in the wrong syringe can be captured with drug administered in wrong device. As a result, the patient then received an overdose and as a consequence developed a hypoglycemia. The medication error is the administration of the drug in a wrong device. And because the overdose results from an error, it is not intentional but can be specified and coded as accidental overdose. And the result is the hypoglycemia. Of course, you have the three LLTs here. If a medication error is reported and it is made clear that there were no clinical consequences, the PTC guidance provides us with two coding options. When it is reported that an intramuscular formulation medication was given intravenously instead of intramuscularly, but the patient did not experience any adverse effects, the preferred option would be to code the medication error, the wrong route of drug administration, alone. The most specific LLT would be intramuscular formulation administered by other route. The alternative approach would be to not only capture the error made, but also the fact that no subsequent complications occurred by assigning LLT no adverse effect. Again, you are free to choose either option, but document your rules and ensure that they are applied consistently. Sometimes potential medication errors are reported. Such incidents should also be captured as specifically as possible. Also, the contributing factor should be captured, like in this example from the PTC document, where it is reported that a pharmacist noticed that the names of two drugs look similar and is concerned that this may result in someone getting a wrong drug. LLT drug name lookalike captures the information about the contributing factor, and LLT potential for medication error, wrong drug, indicates that there is a potential for a medication error, including the error type. Well, you may ask yourself, why do some regulators want to receive this information and are actually very keen to receive such information? In such scenarios, no medication error happened yet, but could, of course, occur in the near future based on the reported contributing factors, like drug name confusion, etc. When understanding the background for these potential errors, regulators can take steps to prevent these errors even before happening. So depending on your local requirements, of course, do not omit such information, but capture all relevant information when receiving similar verbatims, and code both the potential for an error by selecting one of these PTs, and also code the contributing factor or factors. Although not being an AE adverse event, such incidents may need to be included in periodic safety reports. Any questions, Leander?
Yes, we do have a couple of questions. Thanks, Caroline. If we have a medication error case without AEs, do we code also an LLT, no adverse event?
Yes, that's what I've showed earlier. So the PTC guidance provides two options to handle these scenarios. The preferred one is to just only code the potential error. And the alternative solution is to also select a term for no adverse event. And you're free to choose either one, but you have to, of course, handle them consistently and also document your rules in the coding conventions.
Thanks, Caroline. And I also mentioned that you have your specific webinar coming up on medication errors on the
Yes,
25th
I
of
come to this
June.
in a
So,
minute. Yeah.
yeah, lovely. And the second question is, in the previous example that you were giving, insulin syringe is not specified. Can we not consider there is an underdose here? Why an overdose alone?
Let me go back to this here. Resulting in administration of an overdose. This was exactly what was reported. So
So
always code as reported. Yeah. So drug administered a wrong device would be the correct code assignment here. Accidental overdose because it was a medication error that was made. And this was reported, overdose, and the patient then developed a hypoglycemia.
Caroline, no
And
other questions at this time.
okay.
That's it for now. Thank you.
So if you want to have more information about this topic, you can consult the MedDRA term selection points to consider document, the section 3.15, medication errors, accidental exposures, and occupational exposures. So many examples provided there. I only showed a few. You can also read the MedDRA points to consider companion document. In section 3, there is a specific section for medication errors that really provides detailed coding examples, many coding examples, and also has a question and answer section on medication errors. And you can also, of course, you should also be familiar with this whole HLT in SOC injuries, medication errors, and other product use errors and issues of when looking into the MedDRA browser. So these are the the hints that I can give you. What we provide you with is, of course, MedDRA concept descriptions. I've shown you that there are many terms that relate to medication errors in there. And we have additional MedDRA training resources on medication errors, including a separate webinar, MedDRA coding of medication errors, general principles. The next one I will provide is in 2 weeks from now. Then we have a learning management system module, special situations that addresses medication errors. And we have videos on our MedDRA YouTube channel that you can watch that addresses medication errors. So let me shortly show you where to find these documents. If you go to how to use support documentation, here we are. The points to consider documents are on the top. Here is the MedDRA term selection document in different formats, PDF, Word, and HTML format. And here is the companion document, release 3.0. And if you look into the documents, where do I have my, it's too difficult to show you. Here we are. Now, if you look into the document, you will see that there's plenty of examples, many pages addressing medication errors, and many more even in the companion document here. So here, let me go switch back to my slides. And I will now address a topic that may relate also to medication errors, that is overdose, toxicity, and poisoning. If an overdose, poisoning, or toxicity is reported, extract this information and code it accordingly. Poisoning by drugs and drug toxicity are considered synonyms in MedDRA. You will find the relevant terms under the PT toxicity to various agents. You may ask yourself when to consider a high dose as overdose. Well, you saw a concept description in the browser. It says, for the purpose of term selection and analysis of MedDRA-coded data, an overdose is more than the maximum recommended dose, either in quantity and/or concentration, in other words, an excessive dose. And if an overdose is reported with clinical consequences, you would code both the overdose and the resulting events. And if there are no clinical consequences, again, you have two options. The preferred option provided in the PTC document asks to code the overdose only, but you also have the option to select the alternate option and code overdose and no adverse effect. Another advanced principle addressed in the PTC document is death and other patient outcomes. Death, disability, and hospitalization represent patient outcomes and are normally not captured as adverse events or adverse reactions. But if one of these outcomes is the only information received, then you would code as specifically as possible. And also, if a death term would add relevant medical information, you would code it in addition. And here you see an example. Patient experienced a rash and had sudden cardiac death. If you would ignore the information sudden cardiac death and not capture it, you would of course omit relevant clinical information because it can be considered unusual that a rash leads to sudden cardiac death unless the patient had additional medical problems. Suicide and self-harm is another special topic addressed in the PTC guidance. When coding suicide attempts, completed suicides, and self-harm, clearly distinguish between these scenarios. Be as accurate as possible and handle these terms consistently. Do not assume that an overdose, even if it is reported as intentional, relates to a suicide attempt. Same holds true for reports on self-injuries. If suicide attempt or suicide are not mentioned in the report, only code the intentional overdose or self-injury. Remember the basic coding principle: always do not interpret what has been reported by adding information. Code as reported. And if a suicide attempt has a fatal outcome, make sure to capture it as completed suicide. The outcome makes a big difference here and needs to be considered when coding because both are two separate PTs, completed suicide and suicide attempt. And this was actually what an inspector checked in a drug safety database of a pharmaceutical company. He asked for all cases that were coded to LLT suicide attempt, but with fatal outcome, in order to assess the quality of data entry in the database and the coding, of course. So based on what you've just heard, which of these LLTs would one select for a reported death from cerebral hemorrhage? The verbatim specifies an event with the outcome, so death from cerebral hemorrhage. Options would be sudden death, cerebral hemorrhage, or brain death. As just discussed, in such cases we do not need to code the death of the patient because it is an outcome and captured in a separate data field as a seriousness criterion. In our case, the reason for death is reported, and this is what we should capture. LLT brain death means something different. It means that the brain has lost its function, but the patient must not be dead, but may be comatose and depend on life-sustaining measures. So we would code this verbatim to, of course, cerebral hemorrhage, capturing the condition leading to death. But if the outcome death is the only information in a case, then of course an appropriate LLT for the reported circumstances of the death of the patient must be captured. For the reported outcome, patient was found dead. LLT found dead would be the most suitable term assignment as it is closest to what has been reported. LLT death would be too vague, and when assigning LLT death from natural causes or died in sleep, we would add information that was not reported. So in this case, the appropriate fatal outcome LLT has to be coded since this was the only information in the verbatim, found death. Any questions, Leander?
We've got two questions, thanks, Caroline. Is abuse a special situation or not? Are there exceptions? It is listed as expected event for several known drugs.
So drug abuse is of course a specific medical concept. You will find the concept descriptions in the concept description in the browser. So it's intentional by the patient for non-medical, so for non-therapeutic purposes. And that's a concept that needs to be captured, yes. How you handle these events in your database is your decision and depends on regulatory requirements. But it is a separate medical concept, yes.
Thanks, Caroline. And the next one is, what would assisted suicide be coded to?
That's a very specific question. I would need to find in the browser. I'm sure that that MedDRA contains such a term, assisted suicide.
Thanks, Caroline.
But although I'm dealing with MedDRA for many, many years now, I still do not know everything by heart. So the next principle I would like to share with you relates to drug interactions. The term drug interaction covers interaction between drugs, including biological products, but also between drugs and foods, devices, alcohol, etc., etc. If an interaction is reported, then capture the interaction and the subsequent medical events. And here an example. Patient drank cranberry juice, which interacted with anticoagulant drug, causing an INR increase. It is clearly stated by the reporter that an interaction occurred, and we should capture this information. Food interaction. Make sure to code this interaction as specifically as possible, but you may also receive reports, not just food interaction, but drug-drug interactions, drug-alcohol interactions, device interactions, drug-device interactions, drug-disease interactions, herbal interactions, or radiation interactions. Always code as specifically as possible because all these concepts are available in MedDRA. But what if a reporter does not specifically state that an interaction occurred, but only mentions that two or more drugs were taken together and reports a medical event afterwards? In such instances, you should not assume an interaction just because the patient is taken several drugs, but select terms for the reported medical events only. So how would you handle this verbatim now? After taking an antihistamine along with her prescribed proton pump inhibitor, a 53-year-old woman developed vertigo. Would you select drug interaction, NOS, vertigo subjective, vertigo, or would you select drug interaction, or several LLTs even? Think back about what we have discussed regarding interactions just a few seconds ago. Most of you are going for vertigo, but some of you would also select drug interaction or drug interaction NOS. So let me close the poll here. So here we are not told that an interaction occurred. We should not assume it. The only thing that we know is that the patient took two drugs concurrently. We should not assume that an interaction occurred, but code as reported. And we were not told that the vertigo was such subjective, that it was only a feeling of vertigo. So the correct code assignment here would be vertigo. So we are often asked when to use NOS terms and when not. It doesn't really matter, but good practice is to only select NOS, not otherwise specified terms, LLTs, when it is clearly stated in the verbatim that the condition cannot be further specified. So let's have another short break here to address questions before starting with our exercises. Any further questions, Leander?
I'm just clarifying one at the moment, Caroline, but other
Okay,
than that, there's no questions, thanks.
so then let's move on with our exercises. We may not be able to cover all of them because of time constraints, but I wouldn't like to rush through these exercises because this would not be good condition for understanding the different coding scenarios. And it's I have to say that it's really always very difficult to find the right balance between the number of exercises and the time spent on them, because the feedback that we get is very different. Some of you would like to have a quicker uh, view on these exercises in order to cover more. Others would like to have more time to go through the exercises and raise questions. So I will try my best. At first, uh, before searching in your browser, it is always good practice to check what exactly had been reported. So first look at your reported term, the verbatim. Is it a clinical condition, diagnosis, clinical sign or symptoms, an indication for use, test result, an injury that occurred? Is it a procedural term, a procedure that occurred, was made, medication error, product use issue, product quality issue, or a combination of this? And maybe splitting is necessary. The type of reported term will influence where you would look in the browser to find the closest LLT or LLTs that best match your verbatim. If it is a medication error, you would look into the SOC injury. If it is a product quality issue, you would search in the product issue SOC, etc. So now let's start. Here are temporary demonstration passwords for the browser, just in case you don't have your own credentials. That's the new web-based browser. Here is the link to this new web-based browser that will come into play end of this year. Then the old legacy browser will most probably switched off. So make yourself familiar with the new web-based browser. Here's the username and the password. And here the link to the legacy web-based browser. I've shown you. Here's the shortcut on the MedDRA website. Same username, same password. So it's a temporary password only. It's only valid for a few days. And if you lost connection to the poll questions, here again the QR code. First exercise: became colorblind in adolescence. Which LLT would you select here? Color blindness, blindness color blindness acquired, or color blindness acquired in American English? What would you do? Became colorblind in adolescence. Remember that on LLT level you always find American in British English. It's only on the PT level where you find British English only. Let's see where you're going for. Color blindness acquired. Yes, that's the preferred option. And we would, of course, also look for the spelling of the term. So here it's reported in American English. So it's good practice to also then use American English LLT, color blindness acquired. Here we are. Well done. And here is the correct assignment: color blindness acquired. It reflects the acquired nature of the condition and also the appropriate spelling based upon available American British English spelling options. So let me show you in the browser using the legacy browser again and going back to the basic search. If I would enter just colorblind in search, I would find, of course, color blindness immediately. When not checking the hierarchy, you would maybe select this term, although you know it was acquired. Yeah, so it's always good to check the hierarchy, right mouse click, go to browser, and you would immediately see that color blindness is considered a congenital condition because in most instances, color blindness is not acquired but a congenital condition. So that's why the other term here, color blindness acquired, is the best assignment for our verbatim. Here we are, color blindness acquired. It is grouped in eye disorders, and here we are. So that would be the correct code assignment. And you see that it is only single axial term, so has no secondary linkages. It's only linked to eye disorders. Whereas the color blindness, if I go to this one, go to browser, or if I click on it, you see it has primary, so congenital, of course, and a secondary linkage to eye disorders. Next one, turned very greasy. What is reported here? Is it an ill-defined disorder, an unavailable event? Is the skin turning greasy of the patient, or would you call this to unavailable reaction? Remember what we discussed before about ambiguous verbatims and vaguely reported events. So if you cannot get more information, what would you do with this one? Do we know what turned greasy here? Unavailable event is the preferred solution here. Excellent. Let me close it. Is it the skin or hair? Turning greasy may not even affect the patient, but may relate to medicinal product like an ointment, which has become very greasy. So that's why I would not go for the ill-defined disorder, and I wouldn't make the assumption that the skin of the patient turned greasy. We also don't know whether this was a product quality finding. So unavailable reaction would not fit either. We do not know whether the verbatim describes a reaction to a medicinal product. So the best LLT to select here is unavailable event. So here we are. This assignment reflects the ambiguous nature of the reported information, and most of you have selected the correct LLT here, so well done. Thank you. Next one, patient reported a medical problem. How would you handle this verbatim if no additional information can be obtained? This is now the flip side of what we have just seen in the previous example. Here, obviously, the patient is affected. So which LLT would you select? Is it an adverse event? Do we know that? Or shall we code this to unavailable event like before, or unavailable reaction? Do we know that this was a reaction to a medicinal product or something else? See more. So most of you are going for ill-defined disorder. Second option would be unavailable event. So let me close it. In our case, no additional information is available. So otherwise you would of course try to clarify what kind of medical problem the patient suffered from. So the correct answer would be LLT, ill-defined disorder, and most of you have voted for this LLT. The term reflects the fact that the patient was affected by an unspecified, vaguely reported medical problem. Coding to LLT adverse event would imply that the patient was exposed to a medicinal product or study drug. This verbatim could relate to the medical history of the patient, or could be an event in a follow-up period with no drug exposure. We don't know. And the reaction term would even imply causality. So ill-defined disorder would be the correct code assignment here. And here we are. Next one. The patient reported a loss of smell and thought that he might have a COVID-19 infection. what would you code this one to? Which LLT or LLTs would you select? Anosmia, suspected COVID-19, loss of smell, or COVID-19? Look at the verbatim. Patient reported a loss of smell and thought that he might have a COVID-19 infection. Favorites are suspected COVID-19 and loss of smell. So the patient thought that he might have a COVID-19 infection. It was not a definite diagnosis, but a suspect diagnosis plus a related clinical symptom. Therefore, the LLT suspected COVID-19 is more appropriate than LLT COVID-19. And based on the preferred option in the PTC document for MedDRA term selection, we would code both the suspect diagnosis and the related symptom. So, and we would try to be as close to the verbatim as possible in code to loss of smell. Anosmia, of course, is the medical term for loss of smell, but loss of smell was reported. So here we are with a correct code assignment. Most of you have voted for it. The suspect diagnosis is COVID-19, suspected COVID-19, and loss of smell is the clinical symptom associated with the suspect diagnosis. Here we are. Are there questions, Leander?
No questions. Thanks, Caroline.
Next one. What would you do with this one? He was given drug Y to treat BRAF gene mutation related colorectal cancer. What would you do with this one? Which LLT would you select or would you split code? Colorectal cancer, acquired gene mutation, BRAF gene mutation, or colorectal carcinoma are the options. Let's see what you're going for. Colorectal cancer and BRAF gene mutation are the favorite options here. Yes. And colorectal carcinoma and cancer are considered synonyms in MedDRA, but you would always code as close to the verbatim as possible. And what was reported was colorectal cancer. So this would be the correct LLT assignment for the underlying condition. And you would, of course, also capture the BRAF gene mutation because it's relevant for the prognosis and the therapy for the patient. Here we are. Most of you got it right. And here are the correct code assignments. Colorectal cancer and BRAF gene mutation. Infection after surgery is the next one. How would you handle this verbatim? Which LLT would you select? Infection, postoperative wound infection, surgical wound infection, postoperative infection. So if you would enter infection into the browser, you would get hundreds of potential hits for your search. So you will have to make your search more specific by adding the word stem search or for surgery or surgical or a synonym like opera for operation or operative. So let's see what you're going for. Post-operative infection. Exactly. Surgical wound infection would be an interpretation. We don't know whether it was the wound, the surgical wound that got infected. Could be a generalized infection in the patient. So post-operative infection would be the correct code assignments here. And wound infection, assuming a wound infection was, then we would add information to what has been reported. Always code as reported. Here we are. Very well done. Postoperative infection is a correct code assignment. Next one. She was abused by her husband. Is this a physical abuse, spousal abuse, describing a battered wife, or is it a victim of spousal abuse? What is reported here? She was abused by her husband. Let me check what you're going for. Some of you would consider this as physical abuse, spousal abuse. Most of you are voting for victim of spousal abuse. So it is a report about a woman who was abused by her husband. We don't know whether it was a physical abuse, so we cannot assign LLT battered wife or physical abuse. The verbatim may also relate to a verbal, sexual, or psychological abuse. We don't know. So let me show you in the browser again and enter spouse and abuse. And you see we have a spousal abuse, excuse me, and a victim of spousal abuse. If I go to the spousal abuse, LLT, right mouse click, and we are in social circumstances here, and we have an HLT criminal activity, and in this criminal activity HLT you find spousal abuse. So these PTs describe activities of the abuser, like physical abuse, psychological abuse, sexual abuse, spousal abuse. Now let's explore the victim of spousal abuse. And here we have a separate HLT for crime victims. And you see victim of crime, victim of elder abuse, victim of sexual abuse, victim of spousal abuse. And this is exactly what has been reported in our case. So the correct code assignment here is victim of spousal abuse. Next one. The patient was treated with drug Z for rosacea, which is an off-label use of this medication. Unfortunately, she developed severe dizziness. Which LLTs would you select here? So split coding is required. We have an indication for use. We have the information that this drug Z was used off-label. And then we have an adverse event in the patient. She developed severe dizziness. Which LLT or LLTs would you select? Rosacea, off-label use in unapproved indication, off-label use, and or dizziness. Yes, dizziness needs to be captured. Of course, rosacea needs to be captured. That's the indication for use. And the most specific term for the off-label use in this instance, because it's an off-label indication, would be off-label use in unapproved indication. The drug Z was used for rosacea, and this is an off-label use. So this indication is not approved in the respective region or country. Here we are. And rosacea would represent the indication for use. Off-label use in unapproved indication is the most specific term that we can assign for the off-label use of the medication, and dizziness is the event in the patient. Any questions, Leander?
Not at this time, thanks, Caroline.
I hope everything is clear. Next one. A 27-year-old woman took a 2-week course of antibiotics during her pregnancy. She did not experience any side effects. How would you code this verbatim? Maternal exposure during pregnancy, no adverse effect, normal pregnancy. What would you do? Always using the preferred approach. Outlined in the PTC document. A 27-year-old woman took a 2-week course of antibiotics during her pregnancy. Maternal exposure during pregnancy, no adverse effect, could be coded, would be the alternate solution. Normal pregnancy would be an assumption because we are not told that the pregnancy was normal. We only know that the woman did not experience any side effects from the antibiotic therapy. So now you have changed opinions. Here's a screenshot of the related guidance and the points to consider document. In the same chapter, you also find explanations of how to handle coding of events in the child or fetus due to drug exposure of the mother or father. You see that again, the preferred option is to code just the maternal exposure during pregnancy if no adverse effect is reported. But of course, you have the option to also choose the alternate approach, but then again, document your approach in your coding conventions and use it, apply it consistently. So here is the correct code assignment using the preferred approach, maternal exposure during pregnancy. Most of you have voted for this LLT, so well done. And here you see the HLT that MedDRA contains for terms that refer to exposures during pregnancy, delivery, or the lactation period. And you see the first PT, drug exposure before pregnancy, and the third one, exposure during pregnancy, are quite general and vague. They do not specify whether the mother, father, or fetus was exposed. The second PT refers to a fetal exposure to a maternal infection. The next 5 PTs, exposure via breast milk, fetal exposure during delivery, fetal exposure during pregnancy, fetal exposure timing unspecified, fetal exposure via father, can be selected if the report makes clear that the fetus was exposed or when it is suspected that it was exposed. The subsequent 6 PTs refer to maternal exposure, either before pregnancy, during breastfeeding, during delivery, during pregnancy, timing unspecified, or via partner during pregnancy. These PTs are applied when the drug or product exposure affects the mother. And finally, the last 3 PTs, namely paternal exposure before pregnancy, during pregnancy, and timing unspecified, are to be selected when the father is affected by the exposure. And it is really important to precisely distinguish between these very specific terms. Any questions, Leander?
Not on that one, but the previous example, Caroline, if we could go
Yes,
back to that one, if we may, the rosacea one.
yes.
So there's 2 questions that have come in. One was, why was rosacea coded as an AE in this example? It was an
Not
indication.
It was an indication for use, and MedDRA is not only used for adverse event coding, but also for indication coding. That's why it's mentioned here and listed here. So rosacea would be the indication for use of the drug Z.
Thank you. And then somebody was clarifying, so they are assuming that rosacea is not to be selected as an ADR. Is that correct?
Yes, it's not an RDR. It's the indication for use. Needs to be captured as indication for use, but the adverse reaction here is the dizziness in the patient that needs to be captured. and of course the off-label use in an unapproved indication.
Great, thanks for clarifying that,
Yeah.
Caroline. And then we've had a separate question. If we code a reported verbatim separately, are they separate events then?
So if you have to split code, of course you have separate events, and you may have difficulties if you don't find a combination term in MedDRA you would duplicate the event, so to say, as I've demonstrated with the example of gingival metastatic carcinoma. So you would duplicate the event, but you could, of course, during analysis, get this together based on the date of onset of the respective conditions. So it's always difficult, and as mentioned before, you can also decide to prioritize the information that you get and only code one condition and omit some of the information. It really depends on your coding conventions. But mostly it's always advisable to capture as much information as you can with your coding. Any further questions?
No, that we're up to date with all the questions. Thank you.
Okay. A 2-year-old accidentally took his mother's medication. How to approach this verbatim? Would you code this to accidental overdose, accidental exposure to product by child, accidental drug intake by child, or unintended ingestion of product by child? Again, a nice example for the specificity of MedDRA. And you would also try to select the LLT that is closest to our verbatim. 2-year-old accidentally took his mother's medication. Accidental drug intake by child is the favorite selection, and you're perfectly right. Accidental exposure to product by child, you would not capture the fact that the 2-year-old really ingested the drug, and product is too vague. We know it's a medication, it's a drug. And the same holds true for unintended ingestion of product by child. We know it's a drug. So always try to be as specific as possible with your code assignment. Here we are, accidental drug intake by child. And let me show you in the browser again. So now we are going to SOC injury. And here we have the HLGT medication errors and other product use errors and issues. And you have the HLT accidental exposures to product on the top. And if you look into this HLT top down in the browser, you see that there is an accidental exposure to product, but a separate PT for accidental exposure to product by child. Very specific LLTs underneath. Also under this one, accidental exposure to product by child. And we know that our drug was taken. Excuse me. So unintended accidental drug intake by child is the most specific LLT that we can find for our reported condition. You see that there's also an accidental exposure to product by elderly person, so, and also for device exposure, accidental device ingestion by child. So very often device ingestion, here we have by child, to product packaging by child. And you see that something that is quite often reported in pharmacovigilance is the accidental ingestion of product second by children. So everything is captured in this HLT very specifically for different routes of administration, quite vague terms, but also very specific terms, and also differentiation by age group on PT level. Below that, you find the medication errors. You see that they are grouped based on the stage where the error or issue occurred. So administration, dispensing, monitoring, preparation, prescribing, selection, storage, transcribing errors, and communication issues. So if you are interested in this topic, I can only recommend to join the webinar on medication errors, where we go into more details about these terms and how to approach related medication error, verbatims that relate to medication errors and issues. Now here we are. So our last one for today before coming to the end, because the label on the package was missing the wording on dosing information, the patient took the drug twice daily instead of once daily, resulting in the administration of an overdose. So quite a complex verbatim here, because the label on the package was missing the wording on dosing information. That's a product quality issue. The patient took the drug twice daily instead of once daily. That's a medication error resulting from the product quality issue. And then the patient suffered an overdose based on that, because you took the overdose. How would you approach this one? Product label issue, product label missing text. These relate to the product quality issues. Wrong dose administered, once daily dose taken more frequently, or inappropriate schedule of drug administration. This relates to the fact that the patient took the drug twice daily instead of once daily. And how would you code the overdose? Overdose or accidental overdose?
We seem to be only able to click one answer on this one, Caroline.
Oh, that's bad. Oops. Yeah, I'm not able to change this now. Oh, that's bad. So let me show you. So product label issue, of course, is too vague. Label missing is also too vague. We know that there was missing text because the dosing wording on dosing information was missed. So product label missing text would be the correct LRT to reflect the product quality issue that was reported here. Based on that, the patient took the drug twice daily instead of once daily. So once daily dose taken more frequently would be the best approximation to this part of our verbatim. And because then the patient resulted to administer an overdose, and because it was based on an administration error, we would select accidental overdose. So here we are. These would be the correct code assignments. Product label missing text, the most specific term to capture the product quality issue, the label issue. Once daily dose taken more frequently, the most specific term to capture the schedule error, the error in the schedule of dose administration, and the resulting overdose would be coded as accidental overdose because it resulted from a medication error. Any questions?
Thanks, Caroline. Not on that one, but the previous one in relation to how can we assume it's ingested? That's the 2-year-old accidentally took his mother's medication.
Yes. Took his mother's medication. Yeah, so he took it. It's not just that he played with it, but he took it.
So we can assume that that's ingested because took it.
Yeah. So then we have 10 minutes left, so let me move to As I said before, we will not be able to cover all exercises, but I always prefer to really address all your questions during the course and not only at the end. So that's why we don't make all of them, but I hope that it was helpful for you. So at the end, let me now provide you with a summary of some relevant coding tips and hints, what we call the coding pearls. First, I would like to emphasize that MedDRA cannot only be used for adverse event coding, and you saw that in all our exercises today, but also for coding of indications for use, medical history data, risk factors, investigations, medical procedures, etc., etc. So this slide gives you an example of case information in a narrative format that those of you working in drug safety and pharmacovigilance are probably very familiar with. We are provided with information of the indication for use of a drug that is taken by a 75-year-old male. We get information about his medical history, that he suffered colon cancer and is a cigarette smoker, and risk factor. So the cigarette smoker would be the risk factor. The development of an adverse event. So he developed an aortic valve stenosis, and a surgical procedure to treat this condition, so the aortic valve replacement, and a subsequent post-operative complication, a sternal wound infection. So drug X for rheumatoid arthritis. Rheumatoid arthritis would be the indication for use. All this information highlighted in red lettering can be captured with MedDRA. Here now some valuable tips for you. Whenever you are searching for a suitable term for a verbatim or for terms from a narrative like we saw before, first try using the actual words of the reporter. You better use word stems like, for example, pancreas to cover both pancreas and pancreatic for your search. Because if you are too specific in your search, you may not find any results. And you should use singular terms, not plural terms, and replace words with synonyms if you don't find a suitable hit in MedDRA, like for example replace intentional by deliberate or unintentional by accidental when coding errors in medicinal product use, or replacing leg by lower extremity or lower limb, for instance. If you have found a somewhat suitable term, be aware of MedDRA's specificity and always look for LLTs under the same PT that may even better capture the verbatim, and also look for sibling PTs in the same grouping. Because there may be PTs that are better matches to your verbatim that include additional information like, for example, demographic information, acute or chronic information, post-procedural occurrence, etc. Remember the example where we looked at the verbatim reporting a drug exposure by child, the accidental drug exposure by child, where we saw that there is a PT for accidental product exposure, but also a separate PT for accidental product exposure by child. And if you have found a suitable term, always check the hierarchy, where the term lies in MedDRA, in order to reassure yourself that the hierarchy represents your reported condition correctly. Remember our example with acquired color blindness. If we had chosen just color blindness, it would have been in the congenital SOC, and that hierarchy would have been wrong for our coding scenario because the verbatim was referring to an acquired condition. When searching for suitable terms, use the top-down and bottom-up navigation. If you have difficult verbatims, use available resources for clarification, among those also the concept descriptions that you can find in the MedDRA browser I've shown you, and use the advanced search function or restrict your search to a SOC to narrow down your searches when needed, for example, when you get a long list of potential hits in the browser. And of course, you should get more coding training and of course, coding practice via high coding turnover. The more you code, the more experience, the more professional you will get, the more accurate and consistent your coding output will be. This is what we have addressed today. And now is your last chance for questions. Do we have remaining questions, Leander?
No, I'm just scanning just to make sure. No, we don't have any more questions at this time. But as I always say, that one pops in, but it hasn't at the moment, Caroline.
Okay,
Oh,
thank you, Leander. So let me continue then with some useful links that I can provide you with. So a link to our website, to our help desk, to a FAQ section where you may also find useful questions, answers for your questions. Then the MedDRA browsers here. We have the new web-based browser, the link to the new one and the legacy one, and to the mobile web-based browser. Change request submission link, the training schedule, and also to the support documentation. But you, as I've shown you, you also have I've shown you where to find the support documentation, and you also have a shortcut in the browser in order that directly brings you to this support documentation. This is what you will currently find under the header Training Schedule on the MedDRA website for webinars related to coding for May and June this year. So there will be a MedDRA Coding Basics training in French on the 27th of June. This is the one that we have today, the Advanced MedDRA Coding Training. There will be another one in Chinese on the 17th of June. Then we have the so-called Let's Code Together sessions. These are provided in a workshop format for more advanced coders. The next one will be provided in Korean, and then in the second half of the year, further ones will be provided in English. And here are the MedDRA Coding of Medication Error General Principles webinars. So the next one will be provided by myself on the 25th of June. And there will be another one in Korean on the 8th of July. So, and more, of course, will be posted for the second half of the year. So this is just for June and July. You can not only contact the MSSO via our help desk, but also via other communication channels, as you can see when clicking on the button Contact here on the upper right side of the MedDRA website. You'll find us on Facebook, LinkedIn, X, and YouTube. And you can also join English, Spanish, French, Russian, Indian, and Chinese WhatsApp and WeChat groups. And we also offer an online contact form where you can directly type in your questions and submit them. And what may be helpful for you is our YouTube channel, because there you'll find recorded sessions of our training events sorted by trainers. So let me show you where to find it. Here we have again our MedDRA website. If I click on Contact, then this page will open, and then if I click on this icon here, YouTube, it will bring you to our YouTube channel. And here you have all the trainers, and in different languages. You see our colleague Fernando, he is providing training in Brazilian Portuguese. We have webinars in Chinese, in Spanish, in Russian, and also in Korean, where is our colleague here, Uni. So you can select the language that you would like to listen. You can also select the trainer where you are more familiar with. You see that we have recorded sessions of our Let's Code Together here that I provide together with, you see, oops, no, I don't want to to hear that. So you see that you can really listen back to all these webinars to different trainers because everybody has a different styles, different languages. So if you cannot join one of the trainings because of schedule issues or uh, other issues, vacation periods, whatsoever, you can always visit this YouTube channel and listen back to the respective sessions. Of course, you cannot raise any questions, but you have the option to listen back to these recorded webinars. That's what I wanted to show you. And with this, I hope that you found this webinar useful and hope to meet you again in one of the trainings that we offer in the future. Thank you for your interest in today's topic and for your really active participation. And as always, a big thank you to you as well, Leander, for your support today. So enjoy the rest of your day, and I hope to meet you again in the future. Goodbye for now. Bye-bye.
Thanks, everyone. Bye-bye.